On behalf of our co-investigators, Monty and I are delighted to present to you the results of the CONTACT-3 clinical trial. The trial revolves around two drugs that have been shown to be active in metastatic kidney cancer. This was a large international effort, now published in the Lancet, and we feel there are some big potential implications for clinical practice. When we think about the treatment approach for metastatic kidney cancer, it's important to bear in mind that this is very different from other cancer types. Chemotherapy in general does not work for this disease. The two classes of therapy that are most applied are checkpoint inhibitors and targeted therapies. Checkpoint inhibitors are immune-stimulating therapies that work by blocking protein that sit on the surface of either immune cells, usually T cells, or antigen-presenting cells. By doing so, they simply invigorate the anti-tumor immune response. One such treatment that we are using in the current trial is Atezolizumab. The other broad class of drugs that is used in advanced kidney cancer is called targeted therapy and is used mainly for targets inside the cells. Targeted therapies for kidney cancer work by blocking protein that sit at the cell surface and drive intracellular processes that lead to cell growth, to cell division. Cabozantinib blocks several of these proteins, including MET, XL, and the VEGF receptor, and you can see these drug classes represented in this figure.
These days, the most common way to approach patients with metastatic kidney cancer is to use either two checkpoint inhibitors in combination or to use a targeted therapy with a checkpoint inhibitor. If the patient fails to respond to these combination treatments, targeted therapies alone tend to be the standard, with the most common targeted therapy used after prior checkpoint inhibitors being cabozantinib. Now, we've noticed that many of our colleagues in the clinic continue checkpoint inhibitors after failure of prior checkpoint inhibitors, despite very little evidence to support this. That's the basis of the current trial. We wanted to test whether adding a checkpoint inhibitor to targeted therapy with cabozantinib added value specifically in patients that have received prior checkpoint inhibitors in the previous line of therapy. Now, patients were randomized to receive either cabozantinib alone or cabozantinib with atezolizumab. The aim or goal was to really determine if there was a difference in progression-free survival or overall survival. Progression-free survival relates to a delay in cancer growth. We were really struck by the fact that there was very little difference in progression-free survival between patients receiving cabozantinib alone or cabozantinib with atezolizumab. There also seems to be very little difference in terms of overall survival as well. The median progression-free survival was 10.6 months with cabozantinib and atezolizumab, as compared to 10.8 months with cabozantinib alone. Overall survival was 25.7 months with cabozantinib with atezolizumab, but not reached in patients receiving cabozantinib alone. The hazard ratio approached 1 for both progression-free survival and overall survival, and this really implies that there was not really much of a difference in outcome between the study arms. We were also very curious to know about whether or not there might be specific subsets of kidney cancer patients that could benefit from the addition of atezolizumab to cabozantinib in this setting, but didn't really find any evidence of this. This was irrespective of their line of treatment, the histologic subtype of kidney cancer, or the risk stratification score, known as the IMDC score, a well-validated tool in patients with metastatic kidney cancer.
One of the things that we were most interested in was whether the addition of atezolizumab, the PD-L1 inhibitor, to cabozantinib resulted in additional toxicity. In fact, that's precisely what we identified. And if we look at the rate and grade of 3-4 treatment-related adverse event toxicities, which constitute clinically significant event or death due to treatment or serious treatment adverse event, all these metrics seem to be worse, at least numerically, with the combination of atezolizumab and cabozantinib. I think this is a critical point to keep in mind, in addition to resulting in no additional clinical benefit. So it's possible that adding immune therapy could harm patients in a setting like this. These results should discourage sequential use of immune checkpoint inhibitor in renal cell cancer outside clinical trial. We feel that this study provides not just the kidney cancer community, but the oncology community large, important lessons. Broadly, our study should hopefully put a dent in the current practice re-challenging with checkpoint inhibitor, PD-1 and PD-L1 inhibitor, after prior checkpoint inhibitor therapies, unless there is evidence to support it, and until there is evidence to support it. There are trials with a similar premise as ours that are ongoing in diseases like hepatocellular cancer and lung cancer. Unless we prove that we're adding benefit, we must recognize there is a potential that we may be causing harm, given the safety signal we have observed in the current study. We are immensely grateful to our co-investigators and, of course, to our patients and families that participated in the study.